My name is Dr. Jaime. I am an associate professor of medicine at the University of Miami, Miller School of Medicine, and at the Sylvester Cancer Center in Miami. I'm also the director of a phase 1 program at Sylvester Cancer Center, and my area of clinical interest is in genitourinary tumors. I'm going to present some of the more relevant abstracts and oral presentations that were discussed at the American Society of Clinical Oncology meeting in June of this year. And so I will be focusing on the 3 different disease types on the genitourinary diseases, especially prostate cancer, bladder cancer, and renal cell carcinoma. So in regards of the prostate cancer presentations, I will present 4 abstracts. 2 of them ask a very important question in regards to the role of new generation anti-androgen agents, especially abiraterone acetate, in the treatment of patients with metastatic prostate cancer or in patients with high-risk prostate cancer. So basically, 2 large studies were presented, and the first one, called the latitude study, basically asked a question as to whether patients with newly diagnosed treatment-naive metastatic prostate cancer who are at high risk, and high risk is defined by 2 out of 3 criteria, including a Gleason score of 8 or more, 3 or more sites of bone metastasis, and the presence of visceral metastasis. And so in this group, about 600 patients in each arm were randomized to the control arm, which is hormonal therapy, like LHRH analogs, and placebo, or the experimental arm, which was the standard of care hormonal therapy, and abiraterone at 1,000 milligrams per day, along with prednisone 5 milligrams per day. And the primary objective of the study was overall survival and radiographic progression-free survival. And the results of the study were very, very positive. And they showed that patients who were treated with both hormonal therapy, standard of care, and abiraterone survived significantly longer and had a better improved time to radiologic progression compared to patients on the control arm. In addition to that, other endpoints like time to pain initiation, time to a skeletal event, time to PSA failure, all of them were significantly better in the abiraterone and the hormonal therapy arms. So in conclusion for that study, this was a very positive study, and I would say sets a new standard of care for the treatment of a newly diagnosed patients with metastatic prostate cancer who are at high risk. The other study, which is related to the previous one, is called the STAMPEDE study, and it asked a similar question. Patients were randomized to the control arm, which is standard of care with hormones or radiation, and also all randomized to abiraterone and the standard of care. The difference between the STAMPEDE study and the latitude study is that about half of the patients in the STAMPEDE study had a metastatic disease, like the latitude, but about half of the patients did not have metastatic disease, but they had either lymph node positive prostate cancer at high risk, or even lymph node negative, and the characteristics of the tumor were considered high risk. And the results of the study also were very positive, both in overall survival or failure-free survival in favor of abiraterone. So these 2 studies set the new standard of care, where abiraterone is a clear option for treatments. Other prior options before the studies were chemotherapy with docetaxel, which is a little more toxic, and for 6 cycles, etc. And so this is a good option for patients with this condition. The next set of studies in prostate cancer were in patients with hormone refractory prostate cancer, and the question was whether patients should be treated with enzalutamide, which is a new generation anti-androgen, or abiraterone. And this study showed that while enzalutamide was associated with higher response rates, especially PSA response, it did not differ significantly to abiraterone in regards to progression-free survival. So this study is ongoing, and probably in 1 or 2 years we will know the results of the final endpoint, which would be after alternating or switching treatments to see which group does better. And finally, in the prostate cancer arena, I will talk about a study in regards to whether patients with hormone refractory prostate cancer who are treated with enzalutamide, when they progress on enzalutamide, okay, does it make sense to continue on this drug and not something else like abiraterone or not? So this study, called the Plato study, showed that continuing enzalutamide in addition to a new treatment like abiraterone actually did not improve outcomes compared to just switching to abiraterone. So these were probably some of the most important abstracts in the ASCO that I will be talking about. In the bladder cancer arena, I will be talking about 2 studies, mostly that establish the role of immunotherapy, of checkpoint inhibition in patients with advanced disease. The first study is the KEYNOTE-045, which basically randomized patients to either pembrolizumab at a dose of 200 milligrams IV every 3 weeks, or the choice of chemotherapy for patients who had failed prior cisplatin-based chemo in the advanced setting, or who had recurred within 12 months after a perioperative chemotherapy with cisplatin regimens. And the study here, which was presented last year also at ASCO, this was a longer follow-up, about 18.5 months of median follow-up, and continued to show significant improvement in patients treated with pembrolizumab, both mostly in overall survival and also response rate, while the toxicity was better in the pembrolizumab group. The second study in bladder cancer that I will present is the KEYNOTE-052, which basically is a phase 2 study that is investigating pembrolizumab in the first-line setting, patients not previously treated who are not candidates for cisplatin-based therapies. So about 200 patients were treated, and it basically showed and confirmed the prior data from some time ago, showing that the pembrolizumab is associated with a good response rate in the mid-20% more or less, and also a very good longer-term survival and failure-free survival, while the toxicity was very reasonable. So these 2 studies confirm the role and the benefit of checkpoint inhibitors, in this case pembrolizumab, in either the cisplatin refractory setting or in the first-line setting, first-line treatments in patients who are not candidates for cisplatin. Finally, I will talk about 2 abstracts in kidney cancer. One, which is asking about the role of pazopanib in patients who had a resection of the kidney tumor, a nephrectomy, and were treated with either 1 year of pazopanib at 600 milligrams or placebo. And the primary endpoint was disease-free survival, or basically the number of patients who recur or not. And unfortunately, this study was a negative study. Patients treated with pazopanib for 1 year did not show any significant benefit in terms of disease-free survival compared to placebo. And the conclusion of this study is that pazopanib is not really considered a standard and cannot be recommended as a post-op treatment in the adjuvant setting for RCC. And finally, another study that I will present is mostly a translational study, and this is a study that is trying to validate a new scoring panel that in kidney cancer, which basically is looking at a 16-gene panel that was proven to be associated with prognostic value in kidney cancer. And in this case, they did an analysis, a retrospective analysis of one of the adjuvant trials that was published already, the ESTRAC trial, where patients with high-risk resected renal cell carcinoma were randomized to either sunitinib or placebo, and that study was actually positive in regards to the disease-free survival. So they tried to create associations to determine whether the risk based on this gene panel was associated with a predictive value. And again, unfortunately, the use of this 16-gene panel could not predict whether patients who were taking sunitinib had more benefit or not based on the risk assessed by the panel. But what the study confirmed was the very good prognostic value of this 16-gene panel in both the patients treated with placebo or patients treated with sunitinib. So the conclusions in terms of the renal cell carcinoma studies is that there is no role at this time, or no confirmed role, in terms of improvement in overall survival for tyrosine kinase inhibitors in the adjuvant setting. So I think that is a kind of like an overview of what I will talk today. Thank you.